Okay, well, good afternoon, everyone. Sorry for the delay. We had a little bit of a technical difficulty, but we'll go ahead and get started. Today, the Division of Global Pediatrics is presenting Grand Rounds. My name is Cindy Howard, for those of you who don't know me, and as the Division Director, it's really my pleasure to introduce the topic and our speakers. In fact, this is my favorite Grand Rounds of the whole year because I'm always so proud of our residents and what they have done either at home or abroad on the global health track. So today, the title of the presentation is While They Were Away, Resident Scholarship Abroad. And this presentation gives us the opportunity to hear from three of our most senior residents. First of all, Emily Moody, who is graduating this year in medicine and pediatrics. And she'll be followed by Molly Sajady, who's a senior pediatric resident now. And then finally, our first official global health chief resident, Nate Hare. We have no financial relationships to disclose. We sort of wish we did, but we don't. Our objectives, we hope that when this presentation is over that you'll be able to describe, first of all, ongoing University of Minnesota global pediatric research, to summarize common challenges of doing international research, to understand the strength of collaborations in global child health, and finally, possibly to discover global health opportunities of interest to you. We have 6 international partners, which you can see on this map, and today we'll be spending time in 2 places on either side of the Atlantic, in Bolivia and also Uganda. Each year in Global Peds, we have 10 to 15 residents travel abroad. This past year, 2015-16, we had 12 to travel abroad, and they travel usually to partner sites. No matter where they go, our residents do a scholarly project to learn more about an area of their own personal interest, but more importantly, in an effort to give back to the local community. So we're going to start in Bolivia, and Emily will be presenting safe and enriching environments for children in Bolivia, and you'll see some commonalities in other parts of the world as well. In fact, even here in the United States, you'll be drawing some common threads. Please note that Emily connected with her preceptor in Bolivia prior to going, and she explained her interest and also her expertise and asked Dr. D'Angelo if she might be able to contribute to any ongoing research or projects, educational projects that he had there. And he responded with an idea which caught Emily's interest. She's going to tell us some more.
Thank you, Cindy. As Cindy mentioned, I was in Bolivia for the year. So I was in a slightly rural community called Chilimarca, working on a project that I helped develop kind of before I went and then worked on it more while I was there. I'll tell you a little bit today about Bolivia and about our site there, which I think is actually a really unique site within our Global Health Division. I'll talk about my project a little bit and then give you a little more information about the site because they really have a whole lot of interesting projects going on there. So Bolivia is in the middle of South America. It's one of 2 landlocked countries in South America and the poorest country in South America. I was staying in Chilimarca, which actually, that arrow seems not to have translated well from the other version. Chilimarca is just outside Cochabamba in the middle of the country. And I chose this site in Bolivia for a number of different reasons. I had lived in Bolivia 16 years prior for a year as a high school exchange student. And so I was familiar with the culture, familiar with the language, already fluent in Spanish, written and spoken, and I was really excited to go back to that part of the world. The clinic that I worked at was a primary care and urgent care clinic, which again I think is unique within our global health sites rather than being a hospital site, and I planned to go into primary care, and so that was a big appeal for me. And then I think the biggest draw of that site actually was that they have a really great set of community and public health programs and projects, both within the Chilimarca community and with a much more rural community called Morochata. And I have a background in public health. I went to public health school and studied environmental health prior to medical school. And so I've always been looking for ways to get back into that. And so this site really fit me very well for those reasons. Like I said, Bolivia is considered the poorest nation in South America. The per capita GDP is 6,500. A little bit more tangible, I think, is just to know that 45% of the population lives below the poverty line of $2 a day. And an index that measures income inequality is quite high, one of the highest in South America. So there are huge disparities both within income and health in Bolivia. The infant mortality rate is about 37.5, which according to the World Fact Book through the CIA, that's 58th in the world. The highest infant mortality in South America is in Bolivia. Under 5 mortality is 38 over 1,000. To give a range, the U.S. is about 6.5. The highest is in Angola at 156.9. So Bolivia has a not the worst, but high for South America. And then the maternal mortality rate is 206 per 100,000. Life expectancy is 68, which is low for South America. In the U.S., it's about 79. In the lowest in the world that's measured through the World Fact Book is 49 in Chad. So this is the clinic that I worked at. MAP is the name of the NGO that originally started the clinic about 30 years ago. Up on the top right is Dr. Jose Miguel de Angulo and his wife Stella Losada. He's a general practice physician who moved to Bolivia to start this clinic about 30 years ago. He actually moved from Baltimore, where he had studied public health at Johns Hopkins, which happens to be my alma mater for public health school, so that was a nice connection. In front of the clinic here in the front, you can see me with Dr. Kate Venable, who is one of our global health faculty. She came for about a week to learn more about the projects that they had going on there, and it was really nice to have her there. And then I'm also standing with Teodosia, the head nurse of the clinic, and Freddy Ticona, who is the general physician. My clinic time with them really was collaborative, and so I worked with both of them pretty much daily in clinic, working on different cases together. You can see Freddie on the bottom right, really excited about the Spanish language Harriet Lane that I brought for them. So as I mentioned, one of the really big draws for me about this site was their public health and community projects. This is a reproduction of a poster, and you can see it's all in Spanish, and it's one of their newest projects. And so throughout the 30 years that they've been there, they've really responded to the community in terms of noticing what happened to be health problems or what our community needs there. And they've developed a number of different projects responding to those needs. And so they've developed a school, they've developed some Chagas projects, they've developed some projects supporting children with disabilities. And the way Jose Miguel describes it is that over the years they've done projects to support problems that are there, and they feel at this point attacking things in terms of the social determinants of health and really looking at stopping cycles of violence and stopping cycles of poverty are what their goals are for the community. In one of their publications, they state it really nicely, saying that their goal is to break patterns of intergenerational transmission of disadvantage, violence, poverty, and ill health. So they've developed this 5-pronged approach to a comprehensive infant mental development framework. And what they plan to do is develop a curriculum that they can use within the community, educating physicians, teachers, families, and everybody about how to best support infant mental development, to provide for the most productive citizens, and to really stop these cultures of violence and poverty. The 5 components, briefly, are physical nutrition, emotional nutrition, cognitive nutrition, self-agency development, and then enriching and safe environments. And that's really where I come in. So as Cindy said, I got in touch with them pretty early before going. I wanted to really be able to contribute to something that they had ongoing. So it wouldn't be a project that I did and then left and said, thanks, goodbye. I wanted to leave something that would be useful for them to continue in their work. And so I told Jose Miguel that I had interest in toxicology and environmental health, and that I would be willing to contribute to anything. And I asked for a specific task. I asked him to say, can you identify something that I can do specifically that would be useful? And he said, actually, that would be great. Our fifth determinant within our model is definitely the weakest in terms of what they've developed already. Nobody there within their group knew much about environmental health. And he asked me to develop a home safety checklist that they could use during home visits going in, to have something as a guide to do home visits. And so I said that would be great. He gave me some information about their model, and I had to kind of go back and learn a little bit about developmental psychology and things that I didn't have a background in, to be able to understand their model. And then I looked around for examples of home safety checklists here. The MDH has some, and friends who work in infant neural development actually provided me with some. And I brought those along with me when I went. And so Hogar Seguro is a safe home, and that's basically what I titled my project for them, which is broadly within their framework. So I felt like in engineering or kind of designing this the way that it made sense to me, but I made a really big attempt to try and keep within their framework so that it would be useful for them. Within their framework of a safe and enriching environment, they had these 6 components. So they said physical safety, biological and chemical, social safety, predictability of routines, and enriching environments were all important parts of a safe environment for children, an enriching environment. And so, like I said, I started with a home safety checklist, and that quickly was really difficult because a lot of things that are on home safety checklists here, like checking the temperature of the water heater to prevent scalds and making sure that there are smoke detectors in every bedroom, are not necessarily relevant in that cultural context. And so I really had to start over. And I felt that it was best done really as a conversation with a family or with a provider, saying, how do we best provide a safe environment? The other challenge for me was that my training was mostly in toxicology and environmental health. And so I had to think a lot more broadly about this and think about home accidents and safety, physical safety. And actually the accident piece was interesting because that's, I think, for them a lot more visible in terms of thinking about what is safe for children. So they think about accidents. Yet our context for talking about traffic accidents and preventing injuries for children starts with car seats and safety belts, which isn't really relevant in their context. So most people don't have private cars, and if they do ride in a car or a taxi, nobody has car seats. And so I really had to think about how I could provide the best professional advice about how to maintain a safe environment for a child within that context, realizing that I can't say you need to have a car seat or you're irresponsible. And so overall, it was a really quite fun project for me. I ended up developing a pretty comprehensive written guide in Spanish that they could use that covers each of these areas in depth, that they can use in workshops, trainings, and they can use in home visits. I then took that and circled back to make a home safety checklist for them. That really is, I think, a lot more broader and talks about broad themes of safe environments for children rather than specific checkboxes. Although some things you can make a checkbox, like all chemicals and pesticides do need to be locked up regardless of where you live. Before I left, I gave about a 2.5-hour presentation for the staff, which included teachers, social workers, lawyers. And it was interesting to me what sorts of questions they asked, because a lot of the chemical safety risk they weren't really familiar with. And so I had a fun time having conversations with them about that. So that was mostly my project. I was going to circle back and tell you about some of the other projects. This is a community group in the rural town of Patamorochata where they have a Chagas remediation program. And so for a lot of reasons, the national Chagas program is not very effective for rural environments. But this group brought quick test cartridges and did Chagas testing in those communities. And then they actually sought donations and brought big piles of cement and plaster to change the homes to reduce Chagas risk. So If you don't remember, Chagas is transmitted by the vicuña, or that's the Spanish word for the kissing bug. And the bug lives in little imperfections or holes in the adobe walls. And so by putting cement and plaster on those walls and floors, you really significantly reduce risk of transmission of Chagas. And so this local women's group basically ran that project and did a lot of local education among themselves about that. On the bottom here is a child with cerebral palsy who had a social worker and a lawyer actually visiting his house and providing education, and taught his family how to do therapies and kind of supportive things for him. This I probably won't have time to talk about, but this is another amazing part of that site. FUBE is Fundación Una Brisa de Esperanza, which is a Breeze of Hope Foundation, which provides advocacy and a lot of services for children who are victims of sexual violence. This foundation was started by Jose Miguel and Stella's daughter. And hopefully we'll be meeting her in a grand rounds at some point next year, I'm hoping. And she'll tell us about some of the really amazing advocacy work that she does, as well as services. This really is an outstanding model within all of South America, potentially all the developing world, for recognizing and advocating for children's rights, victims' rights. They have a big march on the 9th of August that they've started, and so they have a lot of community involvement. And then there's always the social aspect of travel. Like I said, I have a family in Bolivia, and so I was able to go visit them after 16 years and meet all their children and celebrate Mom's birthday. So, questions later?
So we'll take questions at the very end, and now we'll move on to Uganda. So Dr. Molly Sajady will present her work in the study of heavy metals in Ugandan children. Please notice that Molly's approach was a little bit different than Emily's. So when we talk to our residents about going abroad, we like for them to start, if possible, it's not always possible, planning their scholarly project before they go. So Molly has been interested in a long time in malnutrition and development, and that's what we think a lot about in our division. So Molly connected with Dr. Cusick, who's here, our PhD in nutrition and global nutrition specialist, and managed to connect with a project and contribute to a project that Dr. Cusick is the PI for in Uganda. And so with that, Molly's going to come and talk to us a little bit about her project, and then we'll, for the sake of time, I'm going to go ahead and say we're going to move them 30 miles east of where Molly was, from Kampala and Makerere University to Jinja, and Nate will be presenting his work in that area. So Molly, go ahead. You can go ahead and yeah.
Okay, thank you. All right, so like Cindy said, I'm going to present my research on the global health rotation and research portion of my time in Kampala, Uganda. So because I have such interest in child development, nutrition, and public health, it was a great fit for that. And there was already a research project going on with Dr. Cusick's team. Also, I have a sister that is in the Peace Corps in Tanzania, which borders Uganda, and I was planning to travel there anyways this year, so it worked out really well. This is a picture of my sister teaching us how to carry water buckets on our heads in her village, too. So part of the research that's been going on in Uganda deals with heavy metals and the risks associated with child health. And heavy metals are basically essential elements that are 5 times greater density than water. And here, an example on the periodic table. Some of them are essential for humans at lower concentrations, like iron and zinc, but some can also build up in the body and cause toxicities. And many of you, I'm sure, have heard about the lead problems in Flint, Michigan, causing the prevalence of lead toxicity in especially children. And children are more vulnerable than adults because they do have lower toxin elimination rates, and they also have more routes of exposures. So whether it be prenatally through the placenta or breastfeeding postnatally, and then also young children commonly put objects in their mouths. So there's the object-to-mouth ingestion as well. So this is just a map showing where Uganda is. It's a landlocked country on the east side of Africa. And just zooming in a little bit, highlighted Uganda here. And most of my time was spent in Kampala, which is the capital city of Uganda, and it's bordering Lake Victoria there. So Uganda has a population of 37.5 million people, and most of them, or about half of them, are pretty young, under 15 years of age. The life expectancy is quite low. It's 57 years, which is about 20 years less than the United States. And then the poverty headcount ratio, which is the percentage of people living under $1.90 per day, is about 20% there. And then for child health indicators, the under 5 mortality rate is about 69 per 1,000, and that ranks 38th in the world. And then the indicators for malnutrition, so underweight is about 14%, which is below 2 standard deviations for weight for age. And then stunting is about 1/3, which is much higher, and that's below 2 standard deviations for height for age. And then wasting, almost 5%, is the below 2 standard deviations for weight for height. And there are also some kids that are overweight, but it's a very small percentage, under 4%. So my part of the research rotation was for 6 weeks. So like Cindy said, this project has been going on a long time, since September. I've had meetings with Dr. Cusick throughout the year before I went in March. And then when I arrived, I did spend 2 weeks of my time doing clinical work. So spending 1 week in the acute care unit, which is basically the pediatric ICU, and then 1 week in the malnutrition ward, learning about severe acute malnutrition. And then the rest of the time, for 4 weeks, I had originally planned to maybe participate in doing physical exams for the children that we were enrolling in our study. But because the timeline got a little bit delayed, I ended up creating a medical history, physical exam, and developmental milestone form to use for the study, then helping to create the code book for data analysis and the database for entering the study forms. And then we also did some mapping within the area that we were drawing participants from. So this is one of the main buildings of Mulago Hospital in Kampala, and this would be the malnutrition ward, and they call it the Wanamugimu unit, and they try to keep it fun, grass and zebras. So this is the official title of our study that's been going on in Uganda since September. It's the prevalence and predictors of blood levels of heavy metals in Uganda. And like Cindy said, the research team consists of 2 PI investigators, Dr. Cusick, who works in nutrition at the University of Minnesota, and then Dr. Ezekiel Muperi, who is actually the head of pediatrics in Mulago Hospital and is also a PhD researcher. And then I'd also like to recognize Erica Jaramillo, who is our Doris Duke Fellow, who's been living in Uganda for pretty much the whole past year and been really instrumental in this project. And she's actually here with us for this month working on the global health rotation. So it's great to have both Dr. Cusick and Erica here for this. And then I'd also like to recognize Emily, who was our first presenter. And she did a global rotation at Mulago Hospital 2 years ago and got interested in the environmental risk factors and health indicators of the children there. And she actually helped write the grant for this project with Dr. Cusick. So it's really cool. So there's 3 main objectives for the overall study, and that is to establish the blood concentrations of 12 common heavy metals in Ugandan children 6 to 59 months, and then also identify the home environmental and nutrition factors, and then also try to determine if there's an association between the metals and the health indicators. This is a picture of one of the sites where we do a lot of our research planning and meetings, also known as the Blue Container on the Mulago Hospital campus. And we keep a lot of documents there as well. So, like I said, the study started back in the fall. It's a cross-sectional design. 200 homes within the Katanga slum, which is a slum near the Mulago Hospital, were mapped out with GPS coordinates if they had children within the age group that we were looking for. And then 100 participants were then randomly selected for our study. And this is a map. You can see, I don't know if it's put away. So the red area is the Mulago Hospital, and then there's a main road, and there's a triangular area that shows where the Katanga slum area is defined, and it's basically just across the main road from the main hospital. And this is a picture just standing in front of the main road looking towards Katanga, and you can see it has a lower elevation, which does make it prone to flooding. And these are some pictures that Erica took while we were mapping in Katanga, and you can see that when the rains come, the water rises and it makes it really difficult to navigate some of these areas. So when the participants are enrolled, there's 4 forms that we were collecting from them. One is just an environmental questionnaire asking about, do they have exposures to batteries within the house? What type of water do they use for cooking and bathing? We did the medical history, physical exam, and milestones form. We did a blood side analysis and then a lab form for the blood samples. And then the kids, when they came, they got the physical exam. They did 2 fingernail samples to test for zinc, and then 3 blood samples. So one was for plasma and red blood cell analysis, and then one was a rapid test for anemia and malaria. And if they had either of those, they would be offered treatment in the study. And then the third one was for the heavy metal analysis, and a few of them would be lead, cobalt, nickel, zinc, just to name a few, but the rest of them are listed up here. And then this is the form that I helped to develop. It was a medical history and physical exam form. So we mainly just asked, past medical history, any medications that they were taking that were relevant to the area, so anti-malarial, tuberculosis, HIV. And then this was more asking about birth history and breastfeeding. And then this was the developmental section. So we had the ages of 6 months to 5 years, and then the developmental categories across the top. And this was sort of developed like the Ireton is here. And it was based on the CDC milestones. And then this is just the final page with the physical exam, the vitals, the measurements, and some of the lab results. And you can see it was stamped and approved, so we were happy to finally have received that. So apart from the overall study, and one of my secondary objectives that I'm going to hope to look at with the final data will be to see if children with zinc deficiency in our population have delayed developmental milestones. So once the data is collected, this is maybe something I'll look at in the next year or so. And this is important because zinc is necessary for not only growth, immunity, and wound healing, but it's also important for cognitive development. And they have shown that even deficiency during pregnancy can lead to birth defects and behavioral concerns in offspring as well. So this is part of my travels in Africa as well. The left is just a picture of our group in Uganda. We went to Queen Elizabeth National Park and saw the equator, which was really fun. Jen Berger there is another resident that I went with. And on the right side is a picture of my husband and I when we were visiting my sister in Tanzania, and we went to Zanzibar. It was really fun. So highly recommend going if you can. All right. I think it's your turn.
Okay. My name is Nate. I'm the Pediatric Global Health Chief. And I led my own research study in Jinji, Uganda. It's still ongoing on the sensitivity of the lung ultrasound in Ugandan children with radiographic pneumonia. My talk today is going to focus on how I got there, how I got to Jinji, Uganda with my family, teaching bedside ultrasound, and then leading this research project to see how well it performs in that environment. And the answer comes with a lot of my driving interests. I've always wanted to have a career in global health research. I'm interested specifically in implementation research. And this time around, I wanted the full PI experience and to figure out everything that comes with that. And also, I have a young family, so we had to kind of make it all fit. But I did it with a lot of help. And here at the University of Minnesota, I had 3 main mentors, Tina Slusher, Steve Dunlop, and Baba Poka. They were the 3 mentors who helped me a lot along the way, and there were many more. The Peds Global Health Chief year gave me the time available to go on site and be everything from the project manager to acquiring supplies to basically to get the study off the ground after the grant was granted. The Thrasher Early Career Award gave the funds necessary for the study, the patient care costs, the study physician costs. And also main collaborators from people I've met thus far in residency. So the three main ones are Global Health Uganda, which is a research nonprofit who I met in 2014 when I was there as a resident working in Kampala on one of Dr. Chandy John's malaria studies. Hennepin Ultrasound, who I met through my rotations at Hennepin County. They supported the project, and one of their ultrasound fellows came to Uganda to do the initial instruction on ultrasound, and she wrote the scanning protocol for the study. And then lastly, up in Canada, the University of Alberta Peds Radiology chair, we got involved, I met him through his prior research in Jinja, Uganda, which was the site that I was working at, and he was glad to contribute. So today I'll be giving a quick overview of the Pediatric Global Health Chief position as it's new. I'll be talking about what lung ultrasound is and why I studied it in Uganda. And then I'm going to end with, since I don't have research or data to share with you, I'll be sharing lessons learned and from my experience there. It's going to be anecdotes and a mixture of things I would have done differently. So the Global Health Chief position was new this year in 15-16. It's within the division of Global Peds, and it's structured as a neutral position where 6 months of hospice work at Ridges and also Sajady clinics at Fairview University pay for your year, and it frees up the other 6 months to be able to go on site and dedicate time to a project or research in global refugee health. I'm finishing up here in June, and Steph Lawton will be coming on in July as the next chief. So now let's dig into ultrasound here. And to tell you more about it, I'm going to go through the medical problem of pneumonia, the background research on ultrasound to date. We're going to look at the findings of pneumonia on ultrasound, identify the research gap, go through the aims, hypotheses, design, and impact of the study. Pneumonia is the leading cause of death in young children, and specifically in the area where the research is done in sub-Saharan Africa, the estimated proportion of death in children under 5 years attributed to pneumonia is 17 to 26%. I found a survey in 2005 where they did case reviews of the children who passed from pneumonia, and they found that most were delayed multiple days before accessing referral care. When we think about what ultrasound can bring to this situation, we already know that from our research in developed countries that it is a supported imaging alternative to chest X-ray. It's safe, portable, inexpensive, and relatively easy to teach. And in 2015, a meta-analysis published in the Journal of Pediatrics showed that a pooled sensitivity of 95% and a specificity of 91% in diagnosing pneumonia in children. Great. So I'm going to go through a couple video clips. These clips were all taken within the first 2 weeks of my time in Uganda. And when looking at lung ultrasound, it's good to perfect. It's good to first look at normal. And the lungs are mostly made of air, and so you think, well, that's not going to show up well in an ultrasound. And it's true in a way, but what you're seeing here in the lung field, which is below the pleural lining, is a reliable artifact pattern called A-lines. They're repeating horizontal lines that fade into the deep field at the bottom of the image. Here are some ribs, 2 of them. Here's the pleural lining with the sliding sign. And then you can see below the ribs are the acoustic shadows, where the A-lines don't project as well. Now there are 4 findings on ultrasound that are indicative of pneumonia. I'll go through each one. The first is greater than 3 B lines. So B lines, I don't know who named these, but B lines go vertically in your image, and they originate at the pleural lining and shoot down. Normal lung can have up to 3 of these in a given field, but if you have more than 3 of these, it's significant of wet lung. Bronchograms on ultrasound show up as a speckled pattern which moves while the patient is breathing. Consolidation is the third finding, and unlike A lines or B lines, this isn't an artifact. Here you're actually seeing the lung as it's been filled with fluid, and it visualizes well with the machine. It looks often like a solid organ, such as the liver, and so this consolidation is also known as hepatization. When you're first doing ultrasound and you think you see consolidation, check the placement of your probe, you're probably down at the liver. The last finding is effusion, and on ultrasound, fluid is black by default. That's where we set the gain on the machine. And this is a longitudinal view of the lateral right side, and you can see the pleural effusion sliding in and out of view in this area as the patient breathes. Comes in and out, in and out. So, now for 10,000 Ugandan shillings, can someone tell me the finding here in this clip? I have the shillings here. It's worth $3. Anyone? I need one try. Greater than 3 B lines. Close. This is actually stomach artifact. So, sorry, I had to trick you a little bit. But the B lines aren't coming from the pleural lining. They're coming from deeper in the field. And when you're visualizing the left side of the chest, specifically the anterior left lung field, you will come across this stomach artifact from time to time. We were fortunate enough to have this come up in our quality assurance period with our Ugandan physician, and so he was able to kind of learn this pattern, and whenever he'd see B lines there, he'd double check himself the same way he would double check himself if he was seeing consolidation near the liver. So that's what we know about ultrasound. However, no ultrasound studies have been done in low middle income countries, and I think this is important for 2 reasons, and they're kind of on both sides of the machine. One is the patients, and it's conceivably different patient population with different higher rates of tuberculosis, malnutrition, which could affect effusions. You're going to see more complicated cases of pneumonia due to late detection, and also the patients themselves have lower immunization rates. On the other end of the ultrasound machine, we have different operators, conceivably from different educational systems, and also they've gone through training with much less access to readily available imaging and using it as part of their clinical diagnosis. So the aims of the study are primarily to see how well the ultrasound exam performs as a diagnostic test, and we have benchmarks that we're shooting for, and also to see how well the operator's interpretations agree with the ultrasound expert, who will also review the ultrasound clips. 300 children will be enrolled, and their ages are 2 months to 5 years, and we chose this as this is where the mortality of pneumonia is the greatest. It has the potential for the greatest impact. And all children who enrolled already have WHO clinical criteria for pneumonia, and that is they've come in with cough and labored or rapid breathing. They all get an ultrasound done by the study physician, which is later interpreted again by an ultrasound expert, and a chest x-ray done within 24 hours, and that's going to be interpreted by WHO primary endpoint pneumonia criteria. And since this isn't a treatment study, we're focusing on the diagnostic test, all children receive the standard treatment of pneumonia per WHO guidelines. I went through our primary outcomes earlier, the design of the test, but also our secondary objectives are to also, I'm hoping we can characterize the presentation of pneumonia in the region in our study site, evaluate the subsequent clinical course and outcomes of these children, and also see how well the imaging performs within subgroups such as severe pneumonia or severe malnutrition. With this, I envision that the ultrasound could be seen as a way that can aid in diagnosis comparable to chest X-ray, and then you can stepwise move it out as it is more affordable and portable in rural areas where there is no chest X-ray. So ultrasound's use in a rural area could aid in the early diagnosis and management and urgent referral of complicated cases and have an impact on the overall mortality. So now for the somewhat behind the scenes part of the talk. I grouped these in no particular order into just some anecdotes and my own experiences regarding study design, collaborating in global health research, being flexible with time, considering your cultural context, project management, data management, staff training and staff retention, and also conducting global health research with your family. Starting off with study design, I used what was available. The CTSI helped with the grant proposal and did biostatistics and power analysis. But I was also able to find publications to help guide you. If you're looking at studying a diagnostic test and you want to know what the sample size you need, there are actually some pretty nifty nomograms out there. If you know the prevalence of the thing you're testing for, you go over one line and then you go up to the sensitivity specificity cutoff you're shooting for, and then over for the confidence interval, and it gives you a nice little number of how many people you need to enroll. If you're brainstorming ideas and projects, this nomogram was helpful. There was also the STARD checklist, guidelines for publication of diagnostic tests, which was helpful to incorporate early on even with a grant, so that things such as the title of the project, the wording, outcomes that are going to be measured are consistent through the whole project, and I won't be trying to come up with them at the end when it comes to writing the paper. Collaboration is key. In global health research, you're by default collaborating. You're not doing it by yourself. And I built with previous connections and then made more in person. And I found the in-person part is another important thing in global health research. People value your time, meetings, and being there. Once the initial collaboration was established, the ongoing collaboration continues in ways of giving back to the study site. We tried to do multiple CMEs to introduce ultrasound to not just our study team, but to the hospital at large. And then also, I contemplated about how the research as a whole also is a way of giving back staff that are otherwise not paid to be there, supplies which are otherwise not there. And so it's another way of giving back to the hospital. So for example, our study staff, when there are no patients to enroll, they go over and help out with the wards. And that's just kind of a given thing. And if you're planning a study at a global health site, that's a nice way to kind of work with the site. And throughout all of this, be a humble guest. I try to only work and only practice in the ways that in the places that I'd been invited to. Being flexible with time. So I can just summarize by saying I had 2 IRBs under my belt and the ultrasound machine when I arrived, and I thought I'd be enrolling 2 weeks later. It actually took 3 months. And things come up, and I'll go through a few of them, but one of them was just multiple IRBs and you couldn't go through them all at once. You kind of have to go through them in sequence. And while we were waiting for the final Ugandan IRB approvals to come back, we adapted to that and focused on training. And while we waited and getting your supplies ready, so that usually the last thing that happened before you enroll isn't the supplies, it's the actually getting the stamped letter, and then you go. When I arrived, I didn't think that a presidential election would have any real impact on not our presidential election, their presidential election would have any impact on my study. I was pretty sure of our safety and had been reassured by Ugandans. But what I found was that this election year, they don't just have one election day, they have many, and it's spread out for the entire month of February. And with each election day, there's 2 days off on either on both ends, so that people can travel back to their home district. And so if you're there and you're trying to get training and get supplies and have meetings, your whole schedule of your whole month of February just turned into Swiss cheese as far as when people are showing up to work. So maybe I'd like to think back and wonder what would it be like if I would have gone in 2017. It probably would have been the same, but there was definitely the presidential election was a big part of what was going on there. So in all of this, I had to learn skills in project management. And when people had asked me, what are you doing there? How's it going? I say, I feel like I'm juggling things and I don't know when they're going to come back. I don't know when they're going to fall back down to me and I can throw them out and throw them up again. So I kept a short game and a long game going at all times. If something big like another IRB came up, I'd try to get that out the door right away and wait for the return, and then shift my focus to things closer at our site, such as training and supply acquisition. And to kind of manage all of this, I made weekly agendas sent out to both the study staff and then also the mentors and the hospital directors, just so they could kind of keep a pulse of what was going on. And these agendas, I'd say like 50% of the time things happen. And a lot of the times things just got moved from week to week as the time went on. But it set the precedent with the staff that things were happening and things were going to get done eventually as things did fall off and get completed. And to the point where there was one week towards the end where we were wrapping up. I think everything was ready to go. We were just waiting for the last stamped letter. And it was Sunday afternoon, and I got a call from the nurse saying, "What's our agenda for Monday?" I was like, "Oh." Well, I'll send that right out to you, but it's basically the same thing as last week. But it got to the point where she asked me for the agenda, which I was impressed. I worked hard in developing the data forms to keep it as simple as possible. My experience in 2014 with Chandy John's malaria study was a big factor in this. At that time, I had seen medical officers filling out forms and just kind of the length of everything. And so I had some rules in creating my own forms for example, of never asking for something that could be calculated on the back end when you're doing your analysis, and never asking for the same thing twice in different parts of the form, even though that might be the natural thing to do in our clinical documentation habits, such as like the date. It might get, or the date and time. You might get different variables, and then you might have to throw something out or figure out how you're going to reconcile it. And then in regards to where you put this on paper or direct entry into online databases, it all came down to the internet and then your comfort level with taking that chance. For me, we had done a lot of research ahead of time as to what is the internet connection like, how reliable is it. We needed to know that because my wife was working remotely for her job while we were there. And yes, there was internet, but it wasn't reliable. And I didn't want to take the chance of having a down connection, meaning missed patients. So I opted to go for paper, but this is changing. And so I'd say wherever, just get some experience on the ground with the internet connection before you make any of these big decisions as to which data system you invest in. With our training, we tried as much as possible to match the local lecture styles, and part of that was meant sitting in on some of their own CMEs before we gave our own. And then moving forward, we used OSCEs and hands-on experience as much as possible. And that was largely in part due to the nature of ultrasound itself. I also learned to step away and foster autonomy. It felt a lot like senioring. And then towards the end, right before enrollment, trial runs were very, very helpful. Helpful for me as the PI and the manager of everything, trying to make sure everything is accounted for, but also helpful for the staff. I saw a big boost in their confidence and morale when they went through their practice patients. And they're like, oh, we can do this. Okay, they're not like sweating on the first day of enrollment. I wish I didn't have to talk about staff retention, but 2 weeks into, maybe 3 weeks, it's all a blur. 3 weeks into my time there, after we had trained the initial nurse and doctor, we lost both of them for different reasons. One took another job, and the other one was let go because of a reference. A reference came in that there was some falsification of data in their past work. So here I was back at square one, about a month down the drain, and reaching out to a lot of the mentors that I had. I found out this is not an uncommon experience, and just you have to persist through it until you find the team that really connects with the project and is dedicated to the work. And then I tried to keep them captive as much as possible. I was limited. All we have is the study salary, but then I try to find ways of other ways that can fit with their careers. So, for example, Dr. William, he's a generalist at this point. He hasn't yet specialized, but he's interested after this in more of an obstetrics and general surgery career. So he wanted to know more. He wanted to have a more comprehensive handle on ultrasound. So I reached out to the Hennepin County Ultrasound Group, and they gave their online course to him for free. So we could have that as a little bit of foundation and take that wherever he wants. And lastly, with family. I'm going to have to keep this pretty limited. Where to start? It was great to have my family along, and honestly, it was a deal breaker. I wasn't going to do this away from my wife and daughter. And honestly, we were planning on this well in advance. We knew that we were going to Uganda before we even had our daughter. So it was, even with all that planning, it didn't make it really that much easier. We had gone through things like travel medicine, I think understood our risks as far as that went, but what we were completely blindsided by was the fatigue and the stress from just carrying out daily activities like transportation, getting food, all while both balancing work. And it'd be the same type of things that you would work out with your family here. But my advice is if you're going abroad with your family, to get plugged in right away and reach out for support. We don't operate alone here, and my advice would be to don't operate alone when you're living abroad either. And yeah, the most challenging thing were just the daily routine, the daily activities, getting water, getting food, laundry, all those things on top of the work that you're doing. Well, thank you. We talked fast. We had a lot to cover today with the three presenters, but I want to turn it back over to Cindy, who will be leading the question and answer period for all three of us.
Well, thank you, Molly and Emily and Nate. Just excellent presentations. And I have to say that Nate really sets the standard high as Global Health Chief, and it was a great presentation, but by all of you as well. I also wanted to mention that the other residents who aren't presenting today and who traveled abroad will be presenting posters. We have a Global Health graduation next Friday night and the campus. Tomorrow. Yeah, this Friday night, the Campus Club. So anyway, well done, and now we'll just open up to questions. If anyone has any Anything to ask of any of the three? Chris?
The question is for Nate. Do you feel like in the clinic and the hospital you work in, there was a lot of diagnosis of pneumonia and treatment with antibiotics, even though it might have been viral cause? And do you think that there will be a change with the ultrasound in how much antibiotics are used?
So Nate, do you want to come up here? So the question is, the use of ultrasound is distinguishing between viral and bacterial lower respiratory tract disease. Will that decrease antibiotic use?
No, I don't think it will. And we thought about this from an ethical perspective before when we were proposing this study. Our goal isn't to reduce antibiotic use. I think there the mortality rate and the complication is much higher from pneumonia. And our goal was to focus on, we're hoping that ultrasound could address the complications of pneumonia and the severe cases. Because I'd assume that less kids are getting, as a whole, less kids are getting treated for bacterial pneumonia, period, even though more are getting treated for viral pneumonia there. Because the access to care is so much less. So we didn't want to take away the little, like reduce the little access to care that already existed. But good question. I'm not sure.
Follow-up
Yeah.
question is for empyema and if like bronchs need to be done or like surgery, were they done Kampala or would they be flown out or did you ever see that happen?
The question was on was there management, surgical management of empyema and consolidation where I was located as a result of the ultrasound, and the answer is no. They didn't have those capabilities to begin with. I chose to do this study at a smaller hospital, the referral hospital, where basically their interventions were nasal cannula or oxygen by nasal cannula. No intubation, no surgical management, IV fluids and antibiotics. Those are the things that they can offer to the patients there. So I didn't see that.
Another follow-up question. If ultrasound is going to be used in more rural areas, you were using a WHO definition of pneumonia itself. So what do you see as their role? What does ultrasound add to the diagnostic criteria?
The WHO criteria are so broad to begin with. I'm hoping it will give confidence to the severe cases of when they are seeing a severely sick child and they know they have pneumonia by the way they're breathing it, or they're treating for pneumonia by the way their respiratory rate and their coughing. But we all know there can be a lot more going on there, and there's like a lot more urgency or not, just by better understanding if there is an MPIE or consolidation or TB. So it doesn't change the diagnosis at the gate, but I'm hoping it can change management after that.
I was just wondering what the finding was on the ultrasound that you showed.
There was the stomach. Is that the stomach artifact where where there was what looked like B lines?
So was there something that was diagnostic of pneumonia, or it was
No,
a trick
it was
question?
a trick. Yeah. Sorry. Yeah.